So, in earlier class we have finished diabetes mellitus, various treatment algorithms, in what condition what is to be used, type 1, type 2 diabetes, and accordingly what treatment should be done, what are the diabetic complications, etc. Now let us go for another topic in endocrinology, that is thyroid. Actually you have studied it twice earlier. You have studied it in anatomy physiology, and you have studied it in pharmacology recently, that what is thyroid hormone, what is the physiological role of thyroid hormone. I am suggesting, because if we have made this sequence particularly with your own choice, then you should be ready with that. Otherwise, whole purpose of giving you topic much before and asking you to go through will not be of any use. So see that you are reading these things. You have studied it again, what is thyroid hormone role, how it is secreted, what are the various controlling mechanisms for that. If you read it, then it will be helpful for you. Then you have studied various physiological roles. You have seen various problem associated with the thyroid hormone, that is hypothyroidism, hyperthyroidism, in what condition it is there. I am very sure those who have referred book, that is Tortura, they will find it very easy. They will find it that they have already studied it. So hypothyroidism, hyperthyroidism is very nicely given in that book. Very good pictures and all information is there. So I hope if you go for that, it will help you. You take this as an assignment. Then in pharmacology, what you studied is what are various treatments in case of hyperthyroidism and hypothyroidism. And once you know all this, what are various drugs which are used in what condition, and what are their good effects, what are their adverse effects, then it becomes easy. Then you can definitely have a better idea about it. Now our role becomes easy. Please revise that. If you have any difficulty in that, you can ask me. Now how we will understand whether the person is having hypothyroidism or hyperthyroidism? So apart from the signs, symptoms, the very nice pictorial things are given in Tortura. You might have seen it. You can refer it again. What are various signs and symptoms? We shall see it again. Basically, apart from the signs and symptoms which are visible, when the signs and symptoms are visible, example, in case of hypothyroidism, the body temperature falls, heart rate falls, okay, the development decreases. And in hyperthyroidism, body temperature increases, BMR increases. Then the next is the heart rate increases. So these are very typical signs are there, apart from the body changes which are there, like exophthalmos and all other conditions are there. As I told you, please go through. Very good figure photos are given. Now once we understand, once somebody can see the signs, then the endocrinologist can ask for the functions. So the thyroid function test are the actual actual tool to interpret what kind of situation is there. So what the endocrinologist can ask for measurement of TSH, that is thyroid stimulating hormone. The normal range of it is 0.3 to 4 microunits per liter. Then free T4, that is tetraiodothyronine, sorry. So the normal range is 0.7 to 2.1 nanograms per dl. Free T3, that is triiodothyronine, the normal range is 1.4 to 4.4 picogram. Pico is still smaller, picogram per deciliter. Then checking about some antithyroid antibodies. Various antithyroid antibodies can be checked. Okay, we call them as a TPO-AB or TSI types of antibodies are there. Then nuclear scintigraphy, that is we administered the radioiodine, that is iodine 1, 2, 3. This radioiodine you might have studied in inorganic pharmaceutical chemistry, or transium 99M. These are various things which are here and that will be there. And lastly, FNSC. FNSC means fine needle aspiration cytology, that is fine needle is inserted into the nodule. जो गांठ होती है, नोडल मतलब उसमें एक नीडल करके वहाँ से फ्लूइड सक करते हैं और वहाँ से जो सेल आती है वो सेल को चेक करते हैं माइक्रोस्कोप में. सो दैट इज कॉल्ड एज ए FNSC. The alternative to FNSC is called as a biopsy, that is that much portion is surgically tissue is removed and then the pathologist will check it. So these are various function tests to determine the thyroid function. Now which test should be given in what condition? So various bodies are there, American Thyroid Associations are there, then American College of Endocrinologists is there. So when hypothyroidism is suspected, then only TSH is sufficient. Then if TSH and free T4 should be measured when hyperthyroidism is suspected or during routine examinations. Free T3's evaluation is done when there is a this T3, that is triad thyronine related toxicosis is suspected. For the follow-up of treatment, only TSH should be measured. Then total T4 or total T3 should not be asked to do it, and never done this this amino acids during pregnancy or lactation, because that will cause this adverse effects of this radiation image. Now these are 9 squares are there to judge the conditions, okay, on the basis of what's your outcome you get, that is when you have done the test. We have seen that basically 2 tests are very important, that is free T4 and free TSH. These 2 things are to be done. Now these squares give very good information, that is when here what it is, T4 levels. So T4 is high, okay, here it is T4 is high, here T4 is normal, here T4 is low, okay, and simultaneously TSH is low, TSH is normal, TSH is high. Now from start we can have here what it is case, the T4 is high and the TSH is low, okay, T4 is high, TSH is low, that means there is a primary hyperthyroidism, okay. Here the T4 is high, okay, and this TSH is a normal, okay. So we can call it as there is a non-thyroid illness, that is there is no role of thyroid, something is there, or the patient is on L-toxin, that means T4 tablets are there, okay. So if the patient is taking, then definitely T4 level will be higher. Now here again T4 is high, TSH is also high, we will call it as a secondary hyperthyroidism. Why secondary? Because TSH is high, therefore T4 is high, okay. Here TSH is low but T4 is high, so that is primary hyperthyroidism, okay. Now both are normal, there is no problem, there is nothing the case, that is here we call it as a euthyroidism, that is it is a normal case where T4 is also normal, TSH is also normal. But if T4 is normal and TSH is low, we will call it as a subclinical hyperthyroidism, okay. While if TSH is high and T4 is normal, we will call it as a subclinical hypothyroidism. If both are low, it is secondary hypothyroidism. Again, if the T4 is low and TSH is normal, we will call it as a non-thyroid illness, that is NTI. And if the T4 is low and TSH is high, we will call it as a primary hypothyroidism. Now you can remember this is very good explanation. The simple 9 squares will help you to remember various criteria of thyroid hormone. Okay. Now once we judge this, once you get this idea what it is, so you should be having again few things in the mind, that is it is called as a commandments or 10 commandments, we can say, sorry, more than 10 commandments. So these are important. Okay. Usually hypothyroidism can be suspected whenever there is a growth and pubertal delay, there is an unexplained depression, when TSH is the test for hypothyroidism, TSH, then total T4 should be checked for that. Check this 9 square, this one magic we can call. Test cord blood for TSH, that is whether it is there, if it is okay. In all obese patient, the TSH should be must done, okay, so that we should understand. For all pregnant, test TSH plus T4 levels. Postmenopausal, 15% of the females they become hypothyroid, so it is better to check the hypothyroidism in this. Start low and go slow, means start with the low dose and slowly if needed go increase that. Use only L-thyroxine, no other thing, because no T3 is used, although T3 is more powerful, more potent, but it is not used, only L-thyroxine is to be used. This L-thyroxine should always be taken an empty stomach, and the thyroxine should be used, avoid its empirical or unnecessary use, I can say. So what is the algorithm for that? We are measuring, this is the diagnostic algorithm. Go for measurement of TSH. Now there are two things can be possible, either TSH is elevated or TSH is normal. TSH is elevated, then measure the T4, that is okay, that is if it is normal or low, check it for that. If it is there normal, we call it as subclinical hypothyroidism, and if it is low, that is then we will call it as a primary hypothyroidism. Okay. Then check the test for that, go for that, that is whether the person is positive or negative for this TPOs, and if it is there, then ask for this T4 replacement, that is will give thyroid. We will go for the test after some time. Okay. Now these are various conditions which are there, that is helping us to understand various situations. And when if it is normal, everything is normal, then there is no need of test. Okay. So these are various conditions in what the person should be doing in that. So these are the antibodies are there. Yes, TPO positive means this thyroperoxide. Okay, this thyroperoxide, thyroid peroxide is there. That is the enzyme which is normally found in the thyroid gland, and it plays important role in the production of thyroid hormones, and it detects the antibodies against TPO. So this TPO, if it is positive, that means the antibodies are present against it. If TPO is negative, that shows that it is the antibodies are not there. Now if the antibodies are there against it, that means that this TPO is affected. that thyroid peroxidase hormone is enzyme is affected, and therefore you have to supply T4 externally. Okay. If TPO is negative, then you have to go for the further this one. Okay. Now in both cases, again, if it is elevated TSH and low TF, this thyroid hormone, it is low, and this is also there, that is TPO is plus, then we call it as a Hashimoto's disease. For Hashimoto's, again, the details are there in your tutorial, you might have seen it. If not, you just let me know, we can discuss. And if still thyroid is less and there is no antibodies for this thyroperoxidase, that means some other reasons can be there. So this is very simple algorithm that explains the reasons or diagnostic activities for this one, that is what can be the reason in the hypothyroidism. One is very clear, when there is a increase in the size, then we call it as a simple goiter. That is very clear. Okay, that we are not considering over here. The reason is, it is very known that it is because of the iodine deficiency, and because of that TSH will be increasing and T4 T3 will be less, that is known, and till iodine is not given, there will be increase in the size of the thyroid gland, and there will be growth. Similarly, we can have that is algorithm for that, that is how we are having इथे करून दे बेटा, समोरच्या स्टूलला करून टाक. हां, मला माहिती आहे, फक्त एक नजर मी नंतर फिरवेल. हां, कधी वाटलं तर तू परत एखाद दिवशी येऊन मला व्यवस्थित दाखवून दे, थोडं फ्री करून. का आत्ता क्लास आहेत 2-3, आज थोडा वेळ नाही. चल, पण चल तू टाक ग्रुपला, मी सबमिट केलं म्हणून, म्हणजे बाकीच्यांना लक्षात येईल. So this is again detection, that is hyperthyroidism. So again we are measuring TSH and this free T4 levels, that is tetrahydrothioronine levels. Now if there is one by one, if there is a decrease in TSH but increase in T4, so that shows the signs of primary thyrotoxicosis, which is a feature of Graves' disease. Again, Graves' disease you have studied in your anatomy physiology. You go through that. If you are not understood, we can discuss it. Okay. Then, and basically, if you read the physiology, then you can understand. You need not to mug it up actually what is happening. Why? Because this is having very clear-cut relations between it. Okay. How it is relevant, because if the physiology is there and feedback mechanism, if you understand well, then definitely it will help you a lot. Then it shows the features of Graves' disease. If it is yes, then go for the treatment for the Graves' disease. If not, then it may be some other reasons. So give the radioactive iodine, okay, into it, start or give it more. Either it can be given in low doses or high doses. It may be because of the cancer of that particular area, that is adenoma of that area. Then second case may be what, that is there are 4 chances are there, because 2 things you are measuring, TSH and free tetrahydrothioronine you are measuring. So there are, what are the 4 conditions? Both are high, both are low, 1 is high, that is if TSH is high, FT4 is low, or FT4 is high, TSH is low. We are seeing all these conditions. Okay. Now there are chances that there is a decrease in TSH, but there is a normal FT4N, that is normal tetraiodothyronine. So if it is there, then go for measurement of free T3 level, that is triiodothyronine. If it is high, then we will call it as a T3 toxicosis. If it is normal, then we will call it as a subclinical hyperthyroidism, and in that case we will follow up it in 6 to 12 weeks. We will check the reason, whether it was some allergic reaction or something like that, or if it is because of the acute thyroiditis, or because of the iodine reason, or because of the increase in the thyroxine levels. Whatsoever it may be, it can be checked in that conditions. So what is that condition? That there are two situations, that is what, either FT3 is high. If it is high, then it is clear cut sign, that is it is a T3 toxicosis, where this T4 is normal, okay, and TSH is decreased. Now if T3 is also normal, then we will call it as a subclinical hyperthyroidism. Okay. Then where both are more, that is TSH is also more, so definitely when TSH is more, then FT4 can also be more. So that is free tetraiodothyronine, both are more, then we will call it as a pituitary adenoma. That is a problem, that is a sort of cancer or hyperplasia in pituitary gland, and because of this hyperplasia in or cancerous growth in that, there is an increase in the secretion of TRH, that is TSH regulating or thyrotropin regulating hormone. So TRH is high, because of that TSH will be high, because of that TSH is high, T4 will be high. Okay. The TSH is normal, and this other one is also normal. Then go for scanning. What is the reason why people is having sign? Otherwise it should be the normal, when normal TSH and this is normal. Either it can be a normal condition, or go for FNSC, why it is there. So this is how we can think, we can go for diagnosis, or how this diagnosis. See, this is based on your 9 square magic. Just now we have seen this 9 square magic. So this 9 square magic, and then on that basis we are going for this diagnosis of hypothyroidism and diagnosis of hyperthyroidism. Once we understand what kind of it is, then we should know what can be the causes of it. Again, these are given, sign symptoms are, I am repeating again and again, it is given in physiology book like Tortora, etc. So it can increase in the Graves' disease, we call it as a diffuse toxic goiter, then Plummer's disease, okay, that is called as a toxic multinodular goiter. Then toxic phase of subacute thyroiditis, that is inflammation of thyroid gland, SAT, that is subacute thyroiditis. Then toxic single adenoma, okay, that is, or single toxic adenoma, STA. There is a pituitary tumor, therefore there is excess in TSH. We have seen pituitary adenoma just now. Then molar pregnancy and choriocarcinoma, there is increase in the beta type of human the chorionic gonadotropin hormone. These are the beta types, and they causes changes in that. Then metastatic thyroid cancers are there, which causes increase in the hyperthyroidism. There is one disease that is known as stroma ovary, that is dermoid or ovarian tumors are there. Because of this dermoid, a sort of cysts are there which are having hair-like structure. So this dermoid ovary is a very typical phenomenon. People is having sort of cancerous ovarian cysts are there. And one more is there, that is called as a thyrotoxicosis factitia, okay, or because of the drugs like amiodarone. Again, if you remember, during amiodarone we have seen that it can affect the thyroid function or it is compulsory to go for thyroid function tape. If you remember this, please go through again. Where you have seen amiodarone? Anybody remembers?
Arrhythmia.
Very good. Arrhythmias. So in arrhythmias, amiodarone you use, and SSRIs are used in depression. So you check about it, how this when they are used, then it can be affected. Okay, and interferon like drugs. So we can have this summary briefly how it is there in hyperthyroidism. If hyperthyroidism is there because of the Graves disease, okay, then these are various signs we can see, particularly in what kind of age group they are more prominent. That is, if it is Graves disease, it will be more prominent in the age of 20 to 40. Then the percent of it means overall total hyperthyroidism, if you will have, so in if there are 1000 cases, then 600 cases will be from Graves disease. Whether it causes enlargement of thyroid, yes, it causes, but that is called as a diffuse type of enlargement. Whether there is a pain, no, there is no pain. If radioactive iodine uptake, what happens to that? RAIU means there is a much increase of radioactive iodine. That means iodine, what we can say, iodine metabolism increases. Okay. What is the treatment? We go for anti-thyroid drug. Anti-thyroid drug, you have studied it. Okay. Have you studied endocrine system in pharmacology?
Yes, sir.
Have you studied anti-thyroid drugs? Yes or no? Okay, yes, sir. So if you have studied it, fine. Do you know any of the anti-thyroid drug? Can you recall it now? Lugos, iodine. Again, any other? Very good. Propylthiouracil. Very good. Okay, these are various drugs which are there. They are called as anti-thyroid agents. They are used. Then toxic multinodular goiter, usually it occurs in the older people where age is more than 50. The occurrence is in 20% patients. Uh, the how the observation, if you observe the thyroid gland, then it shows lumpy enlargement. When you apply some pressure, then there is slightly pain. There is a slight increase in the radioiodine uptake in this radioactive iodine uptake by the pituitary gland. The treatment is radioactive iodine or surgery, because it is sort of cancer, so either it has to be removed surgically or it has to be destroyed with the radioactive iodine. Same with the adenoma, again here you have to remove this. If it is small one, then you can use anti-thyroid drug. Otherwise, you have to use radioactive iodine, so that radioactive iodine will be taken up and it will be causing the destruction of that. So that is a single adenoma, a small one. It can occur at any age, that means, but more prominently in 35 to 50 age. In 5% of the people it can be there. There is a slight single enlargement is there, and no pain is faced by that. Radioactive iodine, it may be or may not be increasing, so we cannot say. Okay. Then that is subacute thyroiditis. It can occur at any age. Around 15% of the person they can have it. There is no enlargement of thyroid gland. Pain is felt by the people. There is a pain, and if you try to give radioactive iodine, then its radioactive iodine is not taken up by the thyroid gland. and for that treatment is NSAIDs and steroids, which are anti-inflammatory in nature. Now in all cases, what was our major diagnostic feature initially? That was where TSH is markedly low and the T4 is highly elevated. Okay, this was our initial sign that helped us to understand or helped us to guide into when we made the further this one, then we got this kind of problems. The next in that is various anti-thyroid drugs. You please go through it. I'll not go in for more details about it. I want assignment on various drugs acting on thyroid gland. Then we'll go for further one. Okay. What we should, if there is a nodules are there, there are two things again possible. TSH secretion either low or high. If it is there, then we'll go for this strontium 99 nuclear scan if there is a hot nodule, or it can be cold nodule. If it is hot nodule, then we'll do with ablation, means burning of the tissue, surgery or anti-thyroid drug, or radioactive iodine. We can do any of this. But if it is cold nodule, then we'll go for FNAC or biopsy. I told you biopsy and FNAC, they are this one. In FNAC only just needle is inserted in that नोड्यूल, जो गांठ है उसमें सिरिंज घुसाते हैं और it is sucked back, blank syringe is sucked. So whatsoever fluid and the cells come into it, they are examined under microscope, that is called as FNAC. And the guided biopsy means this ultrasonicated US means. So ultrasonicated is there, and with that under that that particular portion which is required, that portion is removed out, microsurgery is there, and that portion is then checked under microscope. So that is called as a biopsy. So in that, if we find when this is done, so out of that 100% persons, we can find that 4% may have malignant nodules are there. So if they are malignant, then definitely you have to remove by surgery. There 10% it can be suspicious or follicular type of that. So again it has to be removed by surgery. It can be benign, that is that it is localized, then go for the suppression of T4. We have got various treatments for that. There are chances that cyst can be there, so either apply cytology or go for surgery. And there is a known diagnostic, then repeat FNAC, that what can be the reason, because nothing has been found. So in 17% people it can found that they do not find anything, but still the signs are there. So this is how basically diagnostic we have seen what can be there, and basic treatment. We shall go for other treatment of it in our next class. By that time, I wish that you please go through various drugs which are being used for that as a thyroid, anti-thyroid. After that, we shall go for oral contraceptives, and then all about female sex hormones. So please go through it. If you have any difficulty, you can ask in the meanwhile. Read the physiology well. I told you many times, it will help you to understand it in better way. Go through it, and if you have any difficulties, you can ask it. Okay? So take care and be safe.